Good evening, everybody, and welcome all of you to the 61st live edition of our webinar series in orthopedic principles. We have Santosh Venkatachalam back with us after a small break, and he's going to discuss about the approach towards a radial nerve palsy when it comes for the FRCS exam. Over to you, Santosh.
Thanks, Hitesh. So good evening to people in India, good afternoon for anywhere else. So I'm Santosh Venkatachalam, orthopedic consultant in the UK. I am a current FRCS examiner for clinicals. So one thing I need to do is to put this disclaimer up because I do not want you to take away the points from this presentation and say this is what was told by the examiner, so it is right. These are my own personal opinions and perspectives, and things can change. What is right today may be wrong tomorrow, so take it as a pinch of salt. It's mainly a guide to give you some kind of direction to approach a patient with radial nerve palsy in the exams when you come across it. So important things about radial nerve is that it's the largest nerve in the upper limb. It arises from the posterior cord of the brachial plexus from C5 to T1. So all the roots of the brachial plexus contribute to the radial nerve. It's the most frequently injured nerve in the upper limb. It has a very long and tortuous root. It's quite close to the humeral shaft, and delay in treatment can lead to a poor outcome. So we are focusing on the radial nerve today, and to see a patient who's got a radial nerve problem in the exam scenario and how do we deal with it. So before we go on to knowing how to manage a patient with radial nerve palsy, like anywhere else, we have to go back to our basics, which is the anatomy. So as I said before, it's got a tortuous root. So it's one of the nerves that starts from the brachial plexus in the front under the clavicle, then goes into the posterior compartment, then runs along the bone, comes into the anterior compartment through the lateral intermuscular septum, goes again into the posterior compartment. So you can see it's quite a long route. It goes front, back, and the more it is in close proximity to bones, or the more fascia or septate is passing through, the higher the likelihood of injuries. That is one of the reasons why it's one of the commonest nerves injured in the upper limb. And it's one of the nerves that most of us dread, because some people say even if you look at it, you can have a wrist drop. So you need to be aware of the anatomy and see how to manage. So as I said before, triangular interval, it's formed by the humeral shaft, the long head of triceps, and the teres major. The radial nerve passes through it along with the profunda brachiae artery. Then it comes down further. It's quite close to the bone. In fact, it lies on the bone between the two heads of triceps and in the spiral groove. So as you can imagine, if there is a break or a fracture at this level, there is always a reason for the nerve to get injured, because it depends on the amount of force and the amount of displacement that has happened at the time of impact that can lead to a radial nerve problem. Then after passing through the spiral groove, it goes into the lateral intermuscular septum, varying landmarks as to how high above the lateral epicondyle it will be, but it passes through the lateral intermuscular septum, and that's another fixed point where it comes through, and then passes between the brachialis and brachioradialis and comes further down and divides into its motor and sensory branches. That's the main trunk there. Then you've got the superficial radial nerve, which is a sensory branch, runs under the brachioradialis and ends up supplying the dorsum of the thumb web space. Then you have the posterior intraosseous nerve, which is the main motor branch, and then the supinator, which is where the two branches happen. So you can have the upper part of the supinator is called the arcade of Frost, and that can be one of the common areas for impingement. Because it's such a long nerve and takes such a tortuous route, it has a lot of motor and sensory supply. The main trunk of the radial nerve supplies the triceps, the lateral part of the brachialis, brachioradialis, anconeus, and ECRL. And there's some variations around that area as to what else it can supply. The posterior intraosseous nerve is motor nerve, and it supplies all the forearm, wrist, and metacarpophalangeal joint extensors. The sensory part is where you have the main trunk has branches that supply the posterior cutaneous nerve of the arm and lateral cutaneous nerve of the arm. Then you've got the posterior cutaneous nerve of the forearm, and then, as we already mentioned, the superficial radial nerve. So what are the causes of radial nerve palsy? When you have a patient with radial nerve palsy, you need to think of what could be the potential causes. Common ones: fractures, spiral fractures at the junction of distal and lower 1/3. As you can imagine, spiral groove, the radial nerve is located there. Then further below, it's passing through the lateral intermuscular septum. So these are two fixed points. And when there is a fracture and a lot of displacement, a lot of force goes through it, you can see how the nerve can get tethered, or patients can develop a radial nerve problem. It can also happen with mid-shaft radial fractures. Then because of the close proximity of the posterior interosseous nerve, it can get damaged in radial head and neck fractures as well, or during surgeries. Then gunshot or penetrating injuries, again, can cause radial nerve problems. Gunshot, depending on the force that has gone through it, usually the nerve ends are shredded and they're not suitable for primary repair. If it's a clean cut like a knife and you have a penetrating injury where the two ends are severed, it may be more amenable for repair compared to a gunshot. It'll depend on the degree of force that has gone through and the damage that has happened to the nerve. Then one of the things we dread most is iatrogenic, because once this happens, then it is our responsibility. Common things could be plating of the humerus or interlocking nailing. This is mainly due to, in my experience, due to lack of knowledge or for the fear of exposing the nerve. If you know the anatomy and you expose the nerve, then it makes your life a lot more easier. You can confidently do what you need to do, and you know that the nerve is intact. When I started as a junior registrar, it was always, if I don't see the nerve and it's not anywhere close to the metal, I'm okay. And a lot of times I have got away with it, but you're leaving it down to chance. Rather than that, if you know where the anatomy is, where to look for the nerve, isolate the nerve, then you can do whatever with comfort and confidence. So nowadays, as a routine, for anything I fix around where could be close to the radial nerve, one of the things I do is expose the nerve. Adds about 10 or 15 minutes to the actual operation, but it's done and dusted and you know where it is for the rest of the operation. Distal locking, it's very tempting to go through small stab incisions, use a clip, go down to the bone, put the screw, then you think it's fine. Post-op, if the patient has a wrist drop, then you're stuck. So I would make a slightly generous incision, make sure there is no nerve, identify the nerve, and protect it throughout when you do the distal locking. That is my current practice as well. Then posterior interosseous nerve or various branches of the radial nerve, they can get injured when you do arthroscopy of the elbow or the wrist. Distal radius K-wiring, another common operation, you can get branches of the superficial radial nerve. So we need to be aware of these things. Another thing would be compressive neuropathies, Saturday night palsy, where the patient has slept with an extended arm against a hard surface. Between the bone and the hard surface, the radial nerve is squashed, usually neuropraxia, tend to recover quite well, has good prognosis. We've got radial tunnel syndrome and Wartenberg syndrome. It's quite easy to get confused with these terms. Generally, radial tunnel syndrome refers to compressive neuropathy of the posterior interosseous nerve with pain, no motor deficits. And it can happen at various sites. As you mentioned, the superior border of the supinator, which is the arcade of Frost. Then you can have branches coming from the vessels, the recurrent leash of Henry, the lower border of supinator, ECRB, and so on and so forth. So these are common sites for compression neuropathy of the posterior interosseous nerve, which is what is radial tunnel syndrome. Wartenberg syndrome is a different entity. It's a superficial radial nerve entrapment between the brachioradialis and ECRL during pronation. So how do you approach it in the exam? I would say it's like mathematics. If you know what it is, you will get to the answer. You have to follow the sequence, identify which nerve it is, what level. Is it a high radial nerve palsy, low radial nerve palsy? It can be applied to any nerve, not just for the radial nerve. What kind of a lesion is it? Is it neuropraxia, axonotmesis or neurotmesis? Whether the nerve is recovering or not, usually the patients will be able to tell you if they're improving or if there is a tunnel sign and you're progressively monitoring it, that can help you as well. Look at the secondary effects of the nerve injury, whether the joints have become stiff, whether there's any autonomic changes in the upper limb, and then that will dictate what your treatment options are as to what you can offer the patient. So for a radial nerve palsy, the diagnosis, clinically, if it's a low radial nerve palsy, we are looking at posterior interosseous nerve. It's predominantly motor. So you will have weakness in the wrist and finger MCPJ extensors. High radial nerve, in addition to the low radial nerve, you'll also have weakness of the triceps because that's supplied by the trunk of the triceps, and you'll have superficial radial nerve involvement as well. And patient's autonomic zone of the radial nerve is the first web space, and they'll have reduced sensation there. If it's a low radial nerve, there is no sensory implications. And then if you're monitoring the patient, you can check tunnel sign. It grows, the nerve tends to recover at 1 millimeter a day. So it goes from proximal to distal, and you can monitor that way as well. What investigations do you do? Most of the time it's clinical. You would know the diagnosis is fairly obvious, but what worries you is the nerve recovering or not. If it is something you worry about immediately after you've done something and you're not sure if the nerve is entrapped in the fracture site or things like that, you could do an ultrasound or an MRI, but you need an experienced musculoskeletal radiologist who can actually trace the nerve and tell you confidently if it is entrapped or not. And nerve conduction and EMG, they are more useful after Wallerian degeneration has set in. So there's no point doing a nerve conduction study straight after a radial nerve palsy. It's not going to show much at all. You do it after a few months to see if the nerve is recovering, what's happening on the EMG. Those are the kind of changes you're looking for. So generally, the brachioradialis is usually the first muscle that tends to recover after a radial nerve injury. So with regards to the differences, what you find depends on the type of lesion. So there can be neuropraxia, axonautomesis, or neurotomesis. If you do nerve conduction studies in a few months after a neuropraxia, you will find that there is block at the conduction site, but the distal conduction is preserved and there is no fibrillation on EMG. If it is axonautomesis and neurotomesis, you will have block both at and distal to the site of the lesion, and there will be muscle fibrillations present on EMG. The significance of neurotomesis is where there is severance or complete loss of anatomy, and in those situations, it's not likely that the nerve will recover on its own and tends to need some kind of surgical intervention. And we'll talk about what the surgical intervention is in the next slide. Before we go down to that, we need to be understanding what is a nerve in danger. So pretty much like red flag signs for nerve injuries. I tend to say if they have burning or severe pain, that's like the cry of the dying nerve. The nerve is dying and you're getting a lot of pain because of that. Presence of autonomic dysfunction, because that's the last function to go when you have a nerve injury. If there is a distal to proximal tunnels rather than proximal to distal tunnels. And if patient develops a palsy after you've done something, manipulated, fixed, plated, nailed, assume that you've damaged the nerve unless proven otherwise. So it is almost mandatory to explore the nerve. Unless you're really, really confident you've identified the nerve, you've protected it, it's neuropraxia, or you have an ultrasonographer or a radiologist who can tell you confidently that the nerve is not stuck anywhere, and then you can assume it's neuropraxia. But if you have done something and the patient develops a problem, it is your responsibility to disprove that the nerve is damaged. So either by exploration or investigation, doesn't matter, but that becomes an emergent situation as well. So these are the signs for nerve in danger. So be wary of it when you come across these things or the patient complains of these symptoms. How do we manage radial nerve palsies? Key things are to keep the joint supple, in this case, the wrist, and it's sometimes the elbow or the fingers. You don't want the nerve not to be working and waiting for it to recover and the joints to go stiff. Because if they do, once the nerve has recovered, the function will not be restored. So important part is physiotherapy. So get them to keep stretching the joints, keep them as supple as you can. And then you can use dynamic splints that help the joint to be, dynamic wrist splints can be used. As I said before, emergent exploration is indicated if there is a transection or an iatrogenic damage. Fracture per se, let's say somebody comes in with a mid-shaft transverse humeral fracture and the radial nerve palsy, or even somebody with a middle and lower third humerus fracture, majority of it, more than 8 to 9 times out of 10, tend to be neuropraxia, and that's what literature has shown, and they do tend to recover as long as you monitor them and make sure they're okay. So a radial nerve palsy at the time of injury with an associated fracture is not an indication per se to explore the radial nerve. However, if you put a plaster, or if you manipulate it, or if you've done something to the fracture and the patient develops a radial nerve palsy, then that becomes an emergent indication. And if, let's say, the fracture is completely offended and then you have decided to fix the fracture, then it makes sense, and the patient has a radial nerve palsy, it makes sense that it's in the approach, you identify the nerve, document that there is no transection of the nerve, it is plainly bruised grossly, and it will settle, and it's likely to be neuropraxia. At least when you're there, you could do it. There is no harm in that. But just a pure radial nerve palsy associated with the fracture is not an indication to explore the nerve. I hope that makes sense. So when do we do direct nerve repairs? When you have a transected nerve, you can do a primary repair or use sutures, or you can use fibrin glue. The results are fairly similar between the two. If there is a gap and you can't bridge the gap with primary suturing or glue, then you would need to think about nerve grafts. And common nerves that are used are sural nerves or cutaneous nerves of the forearm, which can be locally harvested. What are the prerequisites for a direct nerve repair? We need skeletal stability, a healthy tissue bed, healthy nerve ends, tension-free repair. That's very important. So if there is a gap, there's no point trying to repair it under tension because it's likely to fail, and good soft tissue coverage. So let's assume you've seen somebody, the patient has a radial nerve palsy at the time of the fracture, you've decided to treat it conservatively, the fracture has gone on to heal, but the nerve has not recovered. And your nerve conduction study suggests it is a neurotomesis, and the patient is unlikely to recover with observation. Then you're thinking along the lines of tendon transfers or salvage procedures. It's usually, the nerves can take 12 to 18 months to recover. And beyond this period, if there is no signs of recovery or the patient's starting to lose function because of it, you may need to think about tendon transfers. Again, the rules for tendon transfer are, you need to know what are your potential donors. So you need to have the other nerves that are intact. So when you assess a patient at the exam, it is important to show that you've thought about it and you checked for the median nerve, which is a predominant donor for some of the tendons, and the ulnar nerve, along with a patient who has radial nerve palsy. So the common transfers that we use, the main goals are to restore wrist extension, finger extension, and thumb extension. So things we use are pronator teres for the extensor carpi radialis brevis for wrist extension. You could use the flexor carpi radialis or flexor carpi ulnaris to extensor digitorum communis for extension at the metacarpophalangeal joint. Then the palmaris longus to EPL to restore thumb extension. And the results are reasonable, so it's not a hugely debilitating condition, so it can be salvaged with tendon transfers in the worst case scenario. Prerequisites for tendon transfer, it's fairly basic. You need to know the tendon should have good power, it should be a synergistic muscle, it should be in the line of action, the joint should be supple. More importantly, it will be difficult to do a tendon transfer in a very young child or very elderly patient who's got confusion or dementia. They're not going to be cooperative because there is a process called muscle re-education that's involved after a tendon transfer. So they need to be able to work with physiotherapy to get the tendon to teach its new function and learn with it. So a reasonable level of IQ is important when you consider patients for tendon transfer. So that is pretty much an overview of how you manage somebody with a radial nerve palsy. I've tried to cover most of the relevant points that you would encounter when you see somebody in the clinical setting for in an exam situation or in real life as well. So as I said, keep it mathematical, think about nerves involved, what is the level, what is the type of lesion, what is the level, state of the joint, and then whether the nerve is recovering or not, and then you decide on what type of treatment you can offer. If you're thinking it's neuropraxia or it's a recovering nerve lesion like axonotmesis, you can continue to observe, keep the joint supple, However, if it is a transected nerve or the nerve has failed to recover, think of tendon transfers. Again, for tendon transfers, look at what tendons are available for you to do that and achieve a good result. And that way you'll be able to demonstrate to the examiner that you've gone through the process, you know what you're looking for, and you'll be in a position where you can sail through the station easily. Thank you.
Thank you, Santosh, for that presentation. It was very clear. There are a couple of questions that have come.
Yeah.
One is regarding the time period. So how do you decide what is the optimum period to do a tendon transfer?
Yeah, so as I said, if you're thinking it's axonotmesis and you're thinking that it's likely to recover, you can do serial clinical tunnel signs, make sure it's progressing at 1 millimeter a day, and you're reasonably optimistic. Then you can do serial nerve conduction studies at 3 months, and usually if you have a good neurophysiologist, they can kind of predict and say, look, this nerve is recovering. I'm optimistic that over the next 3 to 6 months, you should recover good function. Otherwise, you can repeat the nerve conduction studies. Generally, we say around a year. It can be a bit sooner if you know that there is no chance this nerve is recovering or it's completely damaged. There is no time frame for it. But usually about 12 months is the average. By the time you're waiting for these investigations, clinically monitoring them, it takes that length of time, I would say.
Do you think an MRI is anyway useful for these? I mean, with a lot of advanced techniques available, whether the nerve is in continuity or not?
Yeah. So I have personally found that it depends on the musculoskeletal radiologist and the experience they have with imaging these. If you obviously have a metalware or something, there'll be a lot of artifacts and you can't appreciate it. But let's say it's tumor related, or there is a fracture that's displaced, or let's say it's you've managed a fracture conservatively and there is callus and you're worried whether it's trapped somewhere there and things like that. A good musculoskeletal radiologist can actually trace the course of the nerve, either by MRI or ultrasound. And fortunately, one of my musculoskeletal radiologists was somebody who'd done post-graduation in India in orthopedics, and he decided to come to UK and switch over. So he's very switched on when it comes to musculoskeletal bits because he's already trained as an orthopedician and now he's looking at the images. So I think it carries weightage if it's done in the right hands.
Okay. The other one is, what is the role for a nerve transfer? There's a lot of talk about a nerve transfer. Suppose you're taking a particular twig of the intact median nerve and redirecting it to the rest of the radial nerve.
So, yeah, there is lots of work that goes on. In the UK, personally, as orthopedic surgeons, we don't do them. The plastic surgeons or orthopedic surgeons with specific nerve repair interest tend to try these. There is also evidence of doing muscle transfers as well, along with the vascular pedicle into the region to restore the muscle function. Personally, I do not have much experience in it, but I think it is reasonable, but the results are not very promising. The reason being is that majority of the times, the patients that we deal with, I've been a consultant for almost 16 years now. I've not referred anybody for a nerve transfer per se, because I know that a tendon transfer will work, or simple procedures like that, salvage procedures tend to work well. So isolated radial nerve, I don't see a huge benefit in nerve transfer procedures. That's been my experience.
The other one was, it's on a particular technique, is on interlocking nailing. Do you do AP locking or a transverse locking for a distal locking for the interlocking nails?
So we tend to prefer AP locking because it's safer. But if we have to, let's say it's a very low fracture and you need a lot more stability and you can't just get away with one distal locking and you're thinking of multi-axial stability, then I would routinely make, rather than a stab incision, I would make an inch or longer, make sure the nerve is away before I put the distal locking screw. But it's safer and worthwhile considering just an AP locking if it's a mid-shaft fracture or higher up and you're achieving it just to in a bridging technique. So that's absolutely acceptable.
Yeah, because when you go lateral, you're invariably going through the nerve. I mean, very close to the nerve.
Correct.
Why should you ever do a transverse locking? We can always do a AP locking with adequate exposure, isn't it?
Correct. I would agree. I mean, I do medical legal reports as well. One of the commonest complaints or negligence or suing against the trust is for a wrist stop after a distal locking procedure. And when you look through the operation notes, it's amazing how many times the surgeon has just put a small stab, put a nail in, put a screw in, and then they have a wrist drop. And then they don't go ahead and explore the nerve to document whether it was intact or not. And they just assume it's neuropraxia, it just goes on. So it's not worth the risk. I think AP is a great option as long as you can achieve it.
I mean, just in context of that scenario, what are the, I mean, do you do nailing often? Because I have reserved nailing to very few indications. One is I do it for segmental. The other one is I do it for pathological fracture. And very rarely I do it for extreme osteopenia. That's all. Those are three indications I do interlocking nailing. Otherwise, I always prefer plating. What do you think?
Yeah, I think it's just a very traditional thing, isn't it? Plating gives us a lot more satisfaction because you get nice compression, great anatomy, expose the nerve, get it out, fix it, posterior approach, anterolateral, whichever approach. I would agree with your indications for locking nail. Those are the few things. If you have a segmental fracture, tumors, again, we do that. If it's osteoporotic, we use the multi-lock or locking nail within a screw that locks into the nail as well. And that seems to give us more stability. So I'd completely agree with you with regards to the indication per se. And maybe there is an argument for doing it for a simple transverse fracture where you have, you can do a distal locking, impact it at the fracture site. But then the question comes, if it's a simple transverse fracture, is there a real indication to fix as well? So, but yeah, I would definitely agree. Plating is what I routinely use for most of the fractures. And the other point is if you're using a nail with a closed reduction, let's say it's a displaced fracture and you decide to do a closed reduction and you feel great about achieving a closed reduction and putting a nail, there are a couple of instances where the surgeon has been caught out because the nerve is trapped at the fracture site. So even if you're using a nail and it's a displaced fracture, there's no harm in the nail. There is no evidence to suggest nail is inferior to the plate, but it's worth exposing the fracture site, making sure there is no nerve at the fracture site when you do the reduction. And then you can still pass a nail. That's absolutely fine.
Yeah, incarceration of the nerve is the last thing you want for a simple transverse fracture.
Yeah, yeah.
The other one would be, suppose you have a young adult, say 20-year-old guy who has a shaft of humerus mid shaft and who presents with a radial nerve palsy, not post reduction, who presents with a radial nerve palsy. What is your approach?
Generally, the current evidence is to observe them. As long as you are happy that the fracture is reasonably aligned and go on to satisfactory healing, there is no real concern about the radial nerve per se. So as I said before, it would not be an absolute indication for me to fix. However, if it's a young guy, very active, and he wants to get back to stuff, and he doesn't want to wait that 6 or 8 weeks to know if the fracture is healed and then deal with the nerve problems, it's a relative indication. You have to discuss the merits and risks associated with it, but not as a routine. I wouldn't explore the nerve, or I wouldn't do the operation to explore the nerve per se. That's what I would say.
What has happened in this part of the world is the moment you see a shaft of humerus which is displaced, it's fixed.
Right.
I mean, I know in the UK, you hardly fix the shaft of humerus because
yeah.
I know that that's a trend there. But really, in this part of the world, shaft of humerus, surgery.
Okay.
Shaft of humerus with radial nerve palsy, 100% surgery with the posterior exposure and identification.
Fine. I mean, I think it's fine. As long as the patient accepts the risks and you're happy that you're not going to cause any further damage, that's absolutely fine. Because let's say if it is my arm and I break it, I would rather have it fixed straight away so that I can get back to work. Depends on the patient demands and expectations. I need my arm to start operating, do my clinic and everything. I don't want to be in a plaster or a brace for 8 weeks, then to be told it's not healing, you need this, need that. So it's weighing merits and risks associated. So I don't think that's completely wrong. But what I would definitely agree with is if you're operating and there is a radial nerve, whether there is a palsy or not, it's probably worth exploring the nerve, making sure it's out of the way when you fix it. I would definitely agree with that side of things. Any other questions at all?
I think, Santosh, that's all we have for today. And thank you for being with us. It has been a pleasure always. I mean, the upper limb sessions have been great. Thank you once again for being with us.